Hello students, myself Dr.Ahmad Salman Jami or you are watching Dr. A.S. Jami, and in our liver pathology playlist we are going to study about hepatocellular carcinoma. So it's a very important topic you are going to study here, and I am going to explain everything about the hepatocellular carcinoma. Hepatocellular carcinoma is the most common primary liver malignancy in adults. Most common. So it this line explains the importance of this topic, and this is the one of the leading cause of cancer related mortality. Lead cause of cancer related mortality. For this you have to if you already watched my cirrhosis video, it's better for you to understand the hepatocellular carcinoma, and we are going to study some of it in this lecture too. So what is the epidemiology? As you already know, I told you it's the most common primary liver malignancy in adults, and fifth most common malignancy, MX malignancy worldwide. And next thing is most common primary liver malignancy in adults. So the incidence rate is very high in Southeast Asia and Africa. In USA, about 70 to 75 years of age, there is peak incidence, and in Africa the peak incidence is in 30 to 40 years. So bad news for males, there is higher chance of development of hepatocellular carcinoma in males than females. So we are going to study about the causes. So first cause is liver cirrhosis. Liver cirrhosis, about 80% of cases have already liver cirrhosis. The next risk factor which can also cause hepatocellular carcinoma are chronic hepatitis B or C virus infection. Next thing is alcoholic liver disease. In complication section of alcoholic liver disease, I explained what it leads to. It leads to liver cirrhosis, and then it leads to hepatocellular carcinoma. In non-alcoholic steatohepatitis is also a risk factor of hepatocellular carcinoma. Next thing is deposition of iron, hemochromatosis in liver is also a risk factor. Next risk factor is copper deposition, Wilson disease, autosomal disease. It's an autosomal disease. Next thing is alpha 1 antitrypsin deficiency. These diseases are all diseases are risk factors of hepatocellular carcinoma. The next thing is hepatic autoimmune diseases like autoimmune hepatitis. So next risk factor is schistosomiasis. Next one is glycogen storage diseases, and the next risk factor is ingestion of aflatoxin present in mushrooms, present in Aspergillus flavus. So these are the risk factors and causes of hepatocellular carcinoma. So how a patient presents to you with hepatocellular carcinoma? As you already know, there is 80% chances of patient already having liver cirrhosis. So patient having liver cirrhotic complications comes to you for normal checkup, or check for comes to you um, for treatment of liver cirrhosis, and you ask him about lab studies and you find out that he is having liver carcinoma. So what clinical features may be present? So in mild clinical features, in early stages usually patient is asymptomatic. So how a patient presents? Patient presents with underlying etiology, cause which with underlying etiology. Like patient comes to you with liver cirrhosis, with complications of liver cirrhosis. In advanced diseases, there is a construction work outside of my house, so there is a disturbance. In advanced disease, the symptoms is of weight loss, anorexia, hepatomegaly, right upper quadrant tenderness, jaundice, ascites. So we are going to touch liver cirrhosis clinical presentation, how a patient presents to us with liver cirrhosis. So in usually in early phases a liver cirrhotic patient is asymptomatic, like incompensated cirrhosis, while when a patient when disease progress, it leads to fatigue, weight loss, abdominal distension, and spider angiomata, which leads to liver cirrhosis decompensated cirrhosis, which manifests as varicose bleeding, ascites, encephalopathy, and jaundice. You are noticing here that these features are present in manifestation of decompensated liver disease. So this is the non-specific feature. This is also a non-specific feature. So jaundice, a dermal feature of cirrhosis. So we are going to study about we have seen that how a patient presents to us. Patient comes to us with a history of liver cirrhosis, and we are noticing that he is jaundiced and he is having abdominal distension, and you palpated and percuss the abdomen and find the fluid in peritoneal cavity. You notice that there is right upper quadrant tenderness, and you palpated the liver and there is a size increased of liver. So in advanced cirrhosis cases, there is no hepatomegaly, the liver shrinks fibrosed. So if a patient is in very advanced disease of cirrhosis, there will be no hepatomegaly, while there will be shrinkage of liver. So in hepatocellular carcinoma, patient may have weight loss history and anorexia. So these are the clinical features of hepatocellular carcinoma. Now we are going to discuss about diagnostics. How will we going to diagnose? We are going to study it in a stepwise pattern. What should be our initial management and what should be our approach? Diagnostic. So in our initial diagnosis, first of all, we are going to study about two things. First is ultrasound abdomen, and next thing is serum alpha fetoprotein level, AFP. So these two things are our initial diagnostic tests. Next thing is, after initial testing, we are going to perform further imaging. What is CT or MRI abdomen? Don't panic, I am going to explain all the all the findings of these tests in later sections. So after CT or MRI, we are going to perform further test, and this one is liver biopsy. So most important in our initial diagnosis, you already know that we are going to perform a liver function test, whether liver is functioning normal or not. Liver synthetic test, that liver is sensing or liver's ability to produce different compounds essential for our normal regulation are present or not. So we are going to test LFTs also. So first thing is ultrasound abdomen. What will we find in ultrasound abdomen? Let's touch it here. So we'll find solid nodules. If typically these nodules are of more than 10 millimeter in size, varying homogeneity and echogenicity. So what will be the like you have found a nodule. Let's say in other words we find a tumor. So how will be the border of tumors? There will be irregular borders of nodules. Irregular borders. So what else we find? We find cirrhosis, liver cirrhosis on our ultrasound. So next test is our alpha fetoprotein. If the value is of alpha fetoprotein is more than 20 nanogram per ml, so it tells that the patient is having increased level of serum alpha protein, in which indicates patient is having liver hepatocellular carcinoma. So CT or MRI, when you are suspecting, highly suspicious of patient having hepatocellular carcinoma, and we are not differentiating in ultrasound abdomen and serum AFP, so we move towards, and if the values are present, then we also move towards the CT or MRI of abdomen. So what will we find? We find lesions with irregular borders with possible signs of local invasions. So without contrast on CT, we find, without contrast on CT, we find hypodense areas or isodense areas. So without contrast on MRI, what will we find in hepatocellular carcinoma? We find hypertense areas or isotense lesions. So with IV contrast, what will we find? We will find arterial phase hyper enhancements. Next thing is we will find enhancing capsule. These findings are indicated of hepatocellular carcinoma. So next thing is we going to perform liver function test and lab studies. In lab studies you are going to perform these tests in all patients, like you are going to perform CBC. In CBC it may shows thrombocytopenia or paraneoplastic erythrocytosis. So we will perform liver chemistries. In it is abnormal, you will find abnormal liver chemistries. So the next test is coagulation screening. In coagulation screening it may be abnormal, or in advanced disease it is abnormal totally. So next test is serum alpha protein level. It is elevated, you will find it elevated. So what will happen? You will also find some paraneoplastic syndromes. In paraneoplastic syndromes of hepatocellular of HCC, depending on clinical present, patient may have hypoglycemia, or patient serum calcium level raised, hypercalcemia. And what else you can also have in paraneoplastic, suspected paraneoplastic syndrome is hypercholesterolemia. Cholesterol. In lipid panel there will be high amount of cholesterol. So when you are going, these all tests are going to perform by your approach should be this: ultrasound abdomen and serum alpha fetoprotein level with CBC, coagulation screening, um, lipid chemistry, liver chemistries, and serum alpha fetoprotein level. You are going to perform these 5 tests or 6 tests in all patients: ultrasound abdomen, serum AFP, CBC, coagulation screen, and liver chemistry. These 5 tests you are going to perform in your initial evaluation. Next you are going to perform CT or MRI. Then you further proceed for to liver biopsy for confirmation. So in last we are going to perform liver biopsy. So what is the indication of liver? If a patient comes to you with cirrhosis and you are suspecting malignancy and imaging is inconclusive, you are not getting those results you are suspecting on clinical basis, so you will go for liver biopsy. So a patient comes to you without cirrhosis, but there is a lesion you are suspicious about in liver, so you will perform liver biopsy. So what are the risks of biopsy? A patient may bleed during sample taking, or tumor may seed to cavities, tumor seeding. So histopathologist after immunostaining will tells you about the findings of uh, liver biopsy. So next thing is, how will we approach for treatment? Very crucial and important step of our treatment. Video is treatment. How you going to proceed for treatment? So initial treatment based on the stage of hepatocellular carcinoma. So you are going to prevent any further deterioration of any liver disease which is associated. So we are going to treat cause. We are going to treat the cause. So if there is any underlying etiology, like there is hepatitis from causing from hepatitis B or C virus, we are going to treat hepatitis by giving antivirals. We can also give chelation therapy if patient is of hemochromatosis. You have to revise all these chromatosis, all the risk factors. Like 80% patient having liver cirrhosis, you are going to cure him or treat him for liver cirrhosis. If there is any other etiology, like I told you in early minutes that what are the risk factors of hepatocellular carcinoma, you are going to treat according to the etiology. So for this you have to watch other videos. So next thing is, we are going to stage of cancer. We are going to treat our staging patient. So first thing is, and treatment plan. Let's make a table. So if a patient comes to you very early stage or early stage of hepatocellular carcinoma comes to you, a patient comes to you in early stages. So it is a curative. You can cure. So what will you do? We will surgically resect the tumor. If there is minimal concomitant liver disease, and if there is significant concomitant liver disease, we'll go for liver transplantation. So next step is, so what else we can do? This is the first line treatment. The second line or alternative treatment in early stage of hepatocellular carcinoma is ablative therapy. Ablative therapy, like you can do radio frequency ablation. So next thing is, if a patient comes to you in intermediate stage of hepatocellular carcinoma, what will we do? We'll do new adjuvant therapy. So if it is in early intermediate state, it is curative. If it is in later stages of intermediate stage, we cannot cure it, non-curative. So what will we do? We'll give loco-regional. You are getting it, loco-regional therapy. That's how you're going to uh, do. We are going to loco-regional therapy with transcatheteral arterial chemoembolization. You getting it? And trans arterial radioembolization. So either whether either it can be curative or non-curative. In curative cases, you are going to perform loco-regional therapy with transcatheter arterial chemoembolization and transarterial radioembolization. So in if a patient comes to you in advanced stage, it is not curative. So first of all, we'll give systemic chemotherapy. First line treatment is ati atezolizumab or bevacizumab. So you have to give systemic chemotherapy in advanced or non-curative hepatocellular carcinoma. So what alternatives we can give to such patients? Alternatives. We can give non-targeted chemotherapy or hepatic artery infusion chemotherapy. If you cannot choose any of these options, as in gastroenterologist or hepatologist or hepatic surgeon, and patient is having advanced stage of hepatocellular carcinoma, you will typically give supportive care only in very advanced stages of supportive care. So high recurrence rate, there is high recurrence rate of after surgical ablative and loco-regional therapies, and adjuvant treatment is not routinely recommended as it has not shown to be effective. So you are getting it. Patient should additionally undergo treatment of underlying etiologies like antiviral therapy for hepatitis C infections. So what are the differential diagnoses we are going to discuss? Differential diagnosis. It can be malignant liver tumor, which shows us metastatic liver disease. intrahepatic cholangiocarcinoma, hepatic angiosarcoma, primary hepatic lymphoma. I am going to tell you all these. Benign liver tumors. You have to listen to me. Tumor. So tumors. First thing is malignant liver tumors or metastatic liver disease. It is the most common liver lesion. Typically primary site is GI tract. A liver tumor which is metastated to other site is called malignant liver tumor. It so closely there is GI tract. So it can invade colon, stomach, pancreas, lung or breast. Usually patient is asymptomatic, but may be manifest as anorexia, malaise, weight loss, jaundice, ascites or features of underlying etiology. So how will we diagnose such patient metastatic liver disease? We will perform, our approach should be this: ultrasound abdomen, liver chemistries, CBC, coagulation screening and alpha fetoproteins. We are going to perform this. In ultrasound abdomen, we'll perform our initial assessment, then we will see what else is also present. Next thing is we are going to perform CT abdomen with contrast. So if a tumor is malignant, we are going to resect all those organs which are having these tumor seedlings. So we are going to resect those tumor sites. We are going to resect those tumor sites. So if tumor is resectable, we are going to perform surgery, or we can give ablative therapy or surgery, systemic chemotherapy. And if there is no if we cannot resect it, we can give ablative therapy. So you are getting it. So next thing is intrahepatic cholangiocarcinoma. What is it? Intrahepatic cholangiocarcinoma, it is the second most common primary malignancy. Second most common primary hepatic malignancy after hepatocellular carcinoma. So how will we diagnose such patient? Then we are going to perform CT abdomen with contrast or MRI abdomen with or without contrast with MRCP. We are going to find there is intrahepatic cholangiocarcinoma. So we are going to treat by liver transplant. So next thing is our, so next is thing is our hepatic angiosarcoma. So it is a rare manifestation of hepatic sarcoma or hepatic malignancy. So it is, if a patient comes to you working in a chemical industry where vinyl chloride, arsenic or thorium dioxide is used, patient has high risk factor of developing hepatic angiosarcoma. Usually patient comes to you with abdominal pain, weight loss, jaundice, ascites and anemia. So and you try to check his blood pressure and you find it hypotensive, and you find out that there is abdominal pain, so you will go for abdomen CT with contrast. So you will find multiple lesions, typically hypervascular. So undergrad students can skip this differential diagnostic part as it is for post graduation level. So next thing is primary hepatic lymphoma. It is also a very rare cause of lymphatic carcinoma. So it risk factor includes HIV, hepatitis B, C and chemical exposure. So next thing is our, so patient comes to you with abdominal pain, fatigue, anorexia, weight loss, jaundice and night sweats. So you are going to perform ultrasound abdomen, MRI or CT abdomen with contrast. So in this case, primary hepatic lymphoma, the diagnostic test is liver biopsy. So benign liver tumors. Benign liver tumors can be hepatic cyst, liver hemangioma, focal nodular hyperplasia, hepatocellular adenoma, AV malformation, arteriovenous malformation, hepatic, there can be hepatic lipoma or nodules, liver nodules in case of cirrhosis. So these are all the differential diagnoses of hepatocellular carcinoma. What is the prognosis of such patients? Prognosis. If a patient comes to you in early stage of hepatocellular carcinoma, the 5-year survival rate of early 5-year survival rate of early stage of hepatocellular carcinoma is more than 70%. So if a patient comes to you in advanced stage, the 5-year survival rate for advanced hepatocellular carcinoma is equal to 20%, more or less than equal 20%. So usually median survival is 1 to 1.5 years. So how we can prevent from developing hepatocellular carcinoma? So primary prevention, this is going to be very important for all the people who are medicine field associated or not. So if you are watching this video, you can watch this part to prevent yourself from developing hepatocellular carcinoma. First is reduces the risk of blood-borne viruses. Like you have to get your immunization done for hepatitis B. Patient should be counseled for safer sex practice. Next thing is early detection and treatment of hepatitis B and C infection. So alcoholic hepatitis disease can also lead to hepatocellular carcinoma. So tells the harm fact of alcohol. Maintain alcohol intake. Do not take large volume of alcohol or take within normal limit if a patient wants to consume. So if you are a Muslim, you cannot consume alcohol. So a patient's education is must about high intake alcohol consumption effects. So we should counsel for alcohol use disorder. So next thing is how we can prevent by manage obesity of patient. Like NASH is associated with hepatocellular carcinoma, is a risk factor. So we are going to manage obesity. How we are going to manage? We are going to tell about diet management, weight management, dietary, exercise, weight loss drugs, and weight loss surgery can also play a role in protection. So how we screen for high risk condition? These are our preventions. So high screen conditions. Screening. So if a patient is having cirrhosis from any cause, we are going to screen every 6 months, regular 6 months screening. So if a patient is having hepatitis B infection, active, or a family history of hepatitis C, or a family history of hepatocellular carcinoma, we are going to screen every 6 months. Family history of HCC. If you are living in Asia, after 40 years of age, men should screen every 6 months. And if you lives in Africa, every 50 years, after 50 years of age, every 6 months you have to screen for hepatocellular carcinoma. So in African individual, it should be more than after 20 years of age. In Asian women, after 50 years of age, 6 months screening should be done. So what are the screening modalities? How we can screen for patient? First, abdomen ultrasound is the preferred screening modality. So next thing is for screening is serum alpha fetoprotein levels. So these are two tests for used for screening of hepatocellular carcinoma. That's all about hepatocellular carcinoma. If you wanted to know the staging or anything else, you should watch Milan classification or Milan staging of liver carcinoma on Google. Thank you so much. That's all about hepatocellular carcinoma.